to the ACRU kickoff meeting. I'm so grateful that everyone was able to join us today. I want to start the day with a little bit of history and gratitude. So, as many of you may know, I was born and raised in Iran. That's me in the 3rd grade, so I've always been a little excitable, as you can tell from that photo over there. And so I moved to Los Angeles from Tehran by myself at the age of 18. No culture shock or anything. And when I look at the kids in my family now who are 18, 19, I'm like, they were babies, and I was a baby. So it was quite a journey I made. And since then, I've been all over the place. So I lived in LA for 9 years, took the MCAT a few times, got into the University of Cincinnati. And after med school, I went to Thomas Jefferson in Philadelphia for my emergency medicine residency. Then went down south, joined my husband where he was doing his ophthalmology residency. I was at the Medical College of Georgia for a year. Then came to the University of Michigan and did the Robert Johnson Foundation Fellowship. Then went to Rand and George Washington University for 2 years. And now I've been back for almost 4 years here. So you can imagine that 26 years, 7 moves, a super supportive husband and 2 cute kids later, that standing before you today, this is how I feel. So, you know, this is not just my work. It is the work of so many people who have collaborated with me and my mentors over the years. And there are the fingerprints of all my mentors on this work. And Bill Barson, who outside of being a shining example of integrity and humility, has taught me how to think about research at the interface of emergency medicine and other disciplines. Matt Davis, who has always pushed me to push the envelope. Art Kellerman, who taught me uncompromising excellence in health services research. Nicole Laurie, who taught me how to think about research from a policy lens. Paul Kogel from Rand, who couldn't be here today, unfortunately, who taught me how to write a winning proposal. And Neil Wenger, who's sitting right here, who has taught me patience and perseverance in research. So thank you, everyone. And of course, Dr. Numar, who's sitting in the back, our chair, who now almost 5 years ago, when I interviewed here for a faculty position, I discussed this idea with him, and about a month later, I sent him a proposal for the unit. And I still have that email, I still have that proposal, and if you look at it, it is indeed what we have today in the ACRU. But I will say that outside of providing me with the discretionary funds to be able to pull this off, to fund the staff that we need, to fund this conference, he has been a supporter, and he has shown up to meetings and convincing people with me that this is really a good idea. And one example here is a meeting that we had with the state now almost 2 years ago. This is folks from the Michigan Department of Health and Human Services. And Bob and I, after this meeting is when they funded this big project that we just recently completed. But this is an example of showing up and supporting the cause for the ACRU. Thank you, Bob. I couldn't have done it without you. And of course, the Institute for Healthcare Policy and Innovation, Dr. Ayanian and his team, thank you so much for including the ACRU as part of the centers and units under IHPI. And also, your team has been so helpful in providing me with the knowledge base of how to put this all together, from the website, from every detail of how to put together this meeting. So they've been available and incredibly helpful to me, and I'm very grateful to your team. And Dr. Rebecca Cunningham and Jason Goldstick from the Injury Center here at the University of Michigan. So Dr. Cunningham, outside of being my mentor and supporter of the ACRU, she recently facilitated a project around surveillance of opioid overdose, and we now have funding for that in collaboration with the Injury Center, and we'll talk about that later. And Jason Goldstick, who's sitting in the front here, who's a statistician extraordinaire, who, without him, the work of the unit would not be possible. And this is Rekar Taimur. For those of you who have not met him, Rekar, I want you to stand up because, are you in the room right there? Okay. All right, so he's the one who's planned this meeting today, and it's been in progress, the planning, since October. All I will say is that we need to figure out a way to clone Ricard. So that would be really good for all of us if we could do that. Thank you, Ricard. Our website, we launched in October, and it's been received really well. So we've had almost 1,500 visitors from a bunch of different states and a whole bunch of different countries. But of note is a very curious thing of over 10% from Russia. So I don't know exactly what that's about, but yeah, we have a lot of interest from Russia in the acute care research unit. So I don't need to tell the crowd here that when you're sick now, that is when you need acute care. And whether it is an infection like pneumonia, whether it is an exacerbation of a chronic disease like asthma or an injury, that you really don't want to wait weeks and sometimes even days to get care. But unfortunately, our healthcare system is ill-equipped and not really designed to be responsive to when you are sick now. And an example of that is not having enough primary care capacity to be responsive to the need of people who are sick today. And hence, that's why this becomes really relevant, the idea for the acute care research unit. Now, you can imagine that when you think about acute care and the acute care continuum, that there are certain populations and certain disease processes that may have their own unique needs so that you can properly and effectively address the needs of those patients. However, ultimately, if you look at the bird's eye view, that a lot of the solutions in providing effective and efficient acute care to patients are agnostic to condition and population. But I will say that when you don't look at the population or the disease state, then that will make your grants or proposals a little more difficult to fund. So, historically, acute care has been delivered and continues to be delivered in silos. So you have the ambulatory care setting, you have the pre-hospital or EMS folks, you have the emergency department folks, you have the inpatient folks. And we function in clinical silos, and also as researchers, we function in silos. And one of the purposes, if not the prime purpose of this unit, is to break down those silos and build bridges between these various care delivery sites. So from the ED to the inpatient, from the inpatient to the ambulatory care, also again from pre-hospital to the ED, and when people go from the ED to ambulatory care, that transitions of care, we need to address issues related to acute care delivery in the sense of the continuum instead of silos. So when you're thinking about coming up with solutions to reduce admissions from the ED, you should be talking to the inpatient physicians. You should be talking to the ambulatory care physicians. And also, how this acute care continuum interfaces with the community at large is also important and needs to be considered. So as our mission is to conduct policy-relevant health services research to address acute care delivery access, cost, utilization, transitions, and effectiveness. And as part of our mission, we incorporate basically questions that transect care delivery sites. So we think about the ED, ambulatory care, and inpatient in one project, and we bring all the folks who need to be at the table and talking and thinking together to those projects. Also in a multidisciplinary and multi-stakeholder fashion. So for example, a project that Brahmaji and Alamatha will be discussing on cardiac arrest, ED folks and cardiology are partnering together. But also there's multiple stakeholders. There's folks from payers, from community representatives, from various organizations, patients who may have to be involved depending on what question you're asking. And oftentimes, due to the complexity of the questions that we're asking about healthcare systems and care delivery, mixed methods really lend themselves to actually these kind of proposals. And multi-institutional. As evidenced by today, we have people from RAND and UCLA, OHSU, Camden Coalition of Healthcare Providers, and Harvard here. And hopefully we can grow the partnership to other institutions across the United States. So again, we have a multidisciplinary and multi-institutional membership. So from medicine, from nursing, social work, public health, policy, and others. And I mentioned our partnering organizations so far. And a diverse funding portfolio, so from foundations to state funding to federal funding, and hopefully we can grow this portfolio. So what goes into the making of an ACRU project? There's a couple of components. So clearly you want the methods experts, depending on what methodology you're using. The content experts that, yes, can include and would include condition-specific and population-specific experts, and also care delivery setting experts. So again, folks who deliver care in the ED, so physicians, nurses, social workers, case managers, counterparts in the inpatient setting and ambulatory care, etc. And the stakeholders. So this may be one of the most important aspects of it, because a lot of my vision for this unit is practical work, stuff that actually has application in the real world, that changes the way we deliver care. And in order to do that, you really need the people who are ultimately the end users of whatever it is that you're producing. And this stakeholder category, including community, government, and providers, are a part of that group. So we have multiple projects right now, and a lot of these will be presented today by my various colleagues. So I'm not going to go into much detail into any of them, but just as a brief introduction. So one of our projects funded by the Emergency Medicine Foundation, identifying patient-centered interventions to reduce pediatric asthma-related ED visits and hospitalizations in Camden. Our colleague Dawn Weist will be presenting that work later today. So the objective here is that in the Camden community, finding patient-centered interventions to help reduce avoidable pediatric asthma-related acute care use. It's a mixed methods project. It crosses multiple care delivery sites, including ambulatory care, ED, inpatient, and our stakeholders are really diverse, including Marie Lazan is right here. She's part of the Community Advisory Board. So we have actually hospital-based care providers, school district, faith-based community, and as care delivery sites, actually also school and home. Because for asthma, there's school nurses who deliver care. There are people who come to kids' homes who actually help with cleaning the home and making sure there's no pollutants and teaching kids and families about how to use their inhalers appropriately. So this is a really good example of how we've used mixed methods and multiple stakeholders and content experts to actually address an acute care delivery-related issue. So the next project, the effect of inpatient occupancy on outcomes for elderly Medicare patients. This is funded by the NIA, and my colleague and mentor, Neil Wenger, will be presenting some of our findings later today. And the goal is to look at the impact of increasing hospital occupancy on patient outcomes. And this is an analysis of a pre-existing data set, and it serves as the basis of a mixed methods grant, R1, that hopefully will get reviewed by the NIA in June. A key stakeholder for the R1 is the California Hospital Quality Institute, which is really the gateway to all the California hospital associations. And identifying healthcare system best practices to address the needs of superutilizers of acute care. So this is a project funded by the Robert Johnson Foundation. I'm one of multiple PIs. Dr. Paula Lance is the primary PI. And so the goal here is to really understand how healthcare systems are addressing the medical and social needs of superutilizers of acute care. And we're using qualitative methodology and surveys. And this study crosses over care delivery sites, including ambulatory care, ED, and inpatient. And there are multiple key stakeholders also represented in the study. So this is the most recently funded project. So it's the design of the system for opioid overdose surveillance, SOS. It is a collaboration between the Michigan Injury Center and ACRU. It is a project that's funded by the Office of National Drug Control Policy. And the objective is to identify hotspots of fatal and non-fatal opioid overdose in order to inform public health and law enforcement interventions. And there's multiple key stakeholders, including public health, again, law enforcement, EMS, and healthcare systems. This is a recently completed project, the Medical Control Authority Assessment Project, where we gave the state 20 policy recommendations regarding best practices for EMS oversight. And it covers the pre-hospital and ED care delivery sites. There are multiple stakeholders, including medical and non-medical first responders, EMS agencies, medical control authorities, and healthcare systems. The main deliverable of a project was a 120-page report for the state and the 20 policy recommendations. And probably the best thing that came out of it was used as the preliminary data for an R01 that was submitted along with Dr. Brahmaji Nalamathu, my co-PI, to the national NHLBI. And it scored a 16th percentile on the first submission, with a cutoff point being 15th percentile. So we were very pleased with that. And this serves as a really good example of how we can, in a multi-institutional, multi-stakeholder and multidisciplinary fashion, kind of have a successful proposal. And Brahmaji will present actually the proposal right after my talk here. So how can we all collaborate today? Moving forward, we're going to have quarterly conference calls, and the folks from Michigan will be an in-person meeting to really to identify opportunities for collaboration. And ACRU members, whether they are here at Michigan or elsewhere, can be PIs, co-Is, or consultants on ACRU-initiated proposals. And the goal would be, so whether Michigan is subcontracting other institutions, or other institutions are subcontracting Michigan, or individuals from other institutions are consultants. Again, there's various ways that this can be done. And you know, ACRU staff could be included on proposals for effort in order to cover some of our expenses and help with the projects, and indeed actually putting the grants together. So for the goals for today are to ultimately get familiar with fellow ACRU members, with current ACRU projects, and network and find opportunities for collaboration, and ultimately get inspired to come up with ideas for ACRU proposals and projects. Thank you so much for being here. I appreciate it.